Now we move on to the next talk by the Chief Instructor, Dr. Sandhya, tackling posterior capsule rent while during phacoemulsification. Dr. Sandhya is a senior cataract and uvea specialist working at Giridhara Institute. Over to you, Dr. Sandhya.
Tackling posterior capsule rent during phacoemulsification. So PCR can produce suboptimal outcome if it is not managed properly. And the consequences of this complication depends on the stage at which it occurs and also the facilities available to manage it. So these are the signs of posterior capsule rent. So this patient was a very high myope, minus 27 diopters, and axial length 35.05 millimeter, and intraocular lens power was minus 9.5 diopters. He also had a posterior polar cataract. All precautions were taken to avoid the occurrence of a posterior capsule rent, but after cortex removal, we placed the IOL inside the capsular bag. So far everything was fine, but during the removal of OVD, a sudden split appeared on the posterior capsule. This was typical of posterior polar cataract, extending from equator to equator, but in this case, the rent has not extended onto the anterior rexus, and the intraocular lens was stable and there was adequate PC support. So the lens was not disturbed. It was kept there, and OVD was removed carefully. Pilocarpine was injected to constrict the pupil, and then before triamcinolone was injected to look for any residual vitreous in the anterior chamber, and none was present. And before withdrawing the irrigating cannula, the side port was aspirated to prevent sudden forward movement of the posterior capsule and IOL, which can cause extension of the rent. And at the end, the pupil was round and the patient had a good visual outcome. So in this patient, during removal of the cortex, the posterior capsule was caught by the IA probe and you could see the radial lines there. And during OVD removal, a large PCR occurred and there was no adequate PC support. And here, this was a 3-piece lens. So we can place this lens in the sulcus. So this was taken out of the capsular bag and placed in the sulcus. Now in this case, this is a single piece lens, and after IOL implantation, a large PC rent was noted. And in this case also, there was no adequate PC support. So we cannot place a single piece lens in the sulcus. So we had to explant this lens. So OVD was injected beneath the lens, and a single piece lens was carefully dialed out of the capsular bag, and the wound was extended a bit, and the IOL was folded on itself and using wound as the fulcrum, this was taken out. There was no obvious vitreous disturbance at this stage, and a 3-piece lens was injected into the anterior chamber, and the 2 haptics were carefully placed over the rexus margin, and then the optic was captured. Once the optic is captured, the round rexus becomes oval shaped or spindle shaped, and when the pupil was constricted, there was peaking of pupil, as you can see here. So this indicates presence of residual vitreous strand, and this was removed by anterior vitrectomy. Now in this patient, during rexus, it has gone to the periphery, and I could not retrieve it. So the rexus was completed by making a nick on the opposite side of the rexus. Since there was compromise in the rexus, vigorous hydrodissection was not done, and the nucleus was not very hard. So it was taken in the anterior chamber and emulsified. But when the last nuclear piece was emulsified, the posterior capsule was caught by the phaco probe. You can see the small piece here and there. So before withdrawing the phaco probe, OVD was injected. This was a dispersive OVD to plug the area of PC rent so that the vitreous doesn't herniate. And then the cortex was removed with the IA cut mode. So by this time, there was vitreous at the wound and this was removed. So when you're introducing the irrigation for anterior vitrectomy into an eye that is already filled with OVD, the infusion pressure was lowered so that there is no sudden deepening of chamber. And then you should use the maximum cut rate that is available with the machine, and it should be in the cut IA mode. And the irrigation should be kept away from the area of the PC rent so that there is no vitreous herniation. And after a good vitrectomy, so you can see there's a slight enlargement of the posterior PCR. And so we have got a rexus extension plus a PCR. But still there was adequate rexus, and the posterior capsule was good enough. So a 3-piece lens was placed in the sulcus, and the optic was captured under the whatever rexus was available there. We had a good overlap of the rexus. Now in this case, PC rent happened during phacoemulsification. The clear area there was overlooked, and with continued irrigation, it got enlarged. So I continued with phacoemulsification. I was lucky that the pieces didn't drop into the vitreous. Actually, I could have stopped there, put dispersive OVD, and moved the pieces away from the area of the rent and emulsified. Or alternatively, I could have used an IOL scaffold technique. Now then, during vitrectomy, the pupil came down, and here again there was a strand of vitreous there, which was indicated by the pupillary peaking, and an iris repositor was used to swipe across the pupillary margin, and the remaining strands were also removed. Now we had to place a 3-piece lens in the sulcus. So visualization of the rexus margin in this case is very important, because we already have a PC rent, and then Kruglan hook was used to retract the iris for visualization, and the 2 haptics were placed on the rexus margin. So in this case, while trenching, I had a giveaway feel, and the nucleus started to tilt. So this was a very hard cataract. So this was converted to SICS. So a separate tunnel, new tunnel was made at a separate new location was chosen for the scleral tunnel, and it is better not to enlarge the original clear corneal incision, because there will be bevel edge and there will be difficulty in taking out the nucleus. So many a times when PC run happens, we will be wondering how it occurred. But most of the time, it is because of our mistake that something we would have overlooked. For example, here, the opening of the aspiration port was directed outside, and that injured the posterior capsule and produced this PC dehiscence. So to summarize, posterior capsule rent should be recognized early. The primary aim is to prevent the enlargement of the tear and to prevent vitreous prolapse into the anterior chamber. If there is already vitreous prolapse, you should remove the vitreous without causing any traction on the vitreous base. And decision on the placement of the intraocular lens depends on the extent of posterior capsule support and adequacy of capsulorhexis. In case of PCR with intact capsulorhexis, you can do a sulcus placement of the 3-piece lens with optic capture. And if PCR is small, you can convert it to posterior capsulorhexis, and a single-piece lens can be placed inside the bag. And SFIOL, iris glow, or AC lens can be considered if there is no adequate capsular support. Thank you.
Thank you, Dr. Sandhya. That's a brilliant talk with a lot of videos. I think we'll